Good afternoon. This is Kelly Sheets with DMS. I will be your host for today's Disparity TAC meeting. I have 1 o'clock, but I believe we only currently have one TAC member on the meeting, so we'll give it a few more minutes and let others join the meeting. I have Julia Richardson. Do we have any other TAC members on that I may have missed? Okay, we'll give it a few more minutes. It is Kelly Sheets again, and I'm using a new headset, and I'm just wondering, making sure that everyone can actually hear me.
Yes.
Okay, thank you. It looks like Patricia Batista Cervera has logged in, but I believe we only currently have two TAC members on, so we'll give it a few more minutes.
Hey, Kelly.
Yes.
Hey there, this is Rachel Rare with DMS.
Uh-huh.
Before we get started, I just wanted to make sure that the TAC members were aware for this call. We have Jeremy Thompson that's joined us, who's with the Transportation Cabinet for this meeting with the Office of Transportation Delivery. And he's here to answer any outstanding questions on the transportation when we presented on July 5th that the TAC members may have. It's not on the agenda, so just to keep in mind if there are questions on that, that he's here for that today.
Okay, thank you, Rachel. As I said, we do currently only have two TAC members on, so hopefully a few more will join here shortly.
Sounds good. Thank you.
I need you to help me with something too. And I thought your light in your bathroom and give it to you. I want you to take it home. You don't have to do that. Well, I have to return it in 30 days if you don't like it. And I want you to make sure it's big enough for what you want. I opened it to see.
Dr. Richardson, do either you or Patricia have any contact information for the other TAC members? Maybe you could remind them of the meeting today?
I'll reach out to Jordan. That's the only, besides just the emails that we
Okay.
have
Okay.
for just the group. That's the only
Right.
contact.
Okay. Thank you so much.
I'm afraid I don't have any contact. I'm sorry.
It's okay.
Hey, Kelly, this is Erin. Can you hear me?
Yes.
I got booted out. What was the ask? I'm sorry. For
We only have,
contacts?
we only have 2 TAC members on, and I was just asking Dr. Richardson, or Patricia if they had, okay, Jordan's coming in right now. If they had maybe a phone number they could reach out, to remind them of the meeting.
The agenda was sent to everyone. I would give it a few more minutes, and in the interest of everyone's time, we should just move forward with the meeting.
Yeah.
I can send out a quick email reminder.
So it looks like Jordan just joined. So Jordan, can you hear me?
I can. Sorry about that.
No, that's okay. We currently only have 3 TAC members on, so we're going to give it a couple more minutes. I think Erin is going to send out an email just to remind some of the other members. And then if we don't have anyone else to log on, we're just going to go ahead and proceed through the agenda.
Okay. I got to.
We won't be able to vote on anything though.
Right.
And then if you can get it started, they do that.
Okay, I'm still not seeing anyone in the waiting room. So if you want to go ahead and start through the agenda, if more members do happen to join, and I believe Keisha Curry is joining right now, and we get to a quorum, I'll let you know and we can go back to the voting items.
Great. All right. Welcome in, everyone. It's the Health Equity Disparity TAC. So, a couple things. Yeah, we said no quorum at this point, so we can't do anything with the previous meeting minutes. At the last meeting, a couple of the different MCOs had started doing the presentations regarding the interpreter services and grievance processes. I think Humana and Anthem had presented on the interpreter services, and Anthem had done the grievance processes. So we can start with the interpreter services presentations by the other MCOs if they're available.
Hey, this is Susan Vickers from Aetna. I'm happy to go ahead with Aetna's deck. We actually have them both on the same deck, so I might have to skip around for a minute if that's okay. Am I able to share my screen? Okay.
I'll have to make you co-host. Give me just a second to do that.
Yeah.
Okay, you should be able to now.
Thank you. Awesome. Oh. Well, I'm making sure I'm sharing the right screen. Okay. Are you all able to see my screen okay?
Yes.
Okay. So I'm sure I'm sorry that I missed the last talk and wasn't able to listen to the other presentations. I'm Susan Vickers. I'm the lead director of quality for Aetna Better Health of Kentucky, and also have Tristan Moyer on the call, who's our population health manager. We worked with our member services leads to better understand and provide the TAC and DMS both with kind of the navigation of our member services phone tree, so that a provider or a member can access the interpreter call line, or what we call the language line. So if there is a request, if a member is in a provider's office, they may always call the Aetna Member Services number. This number is available for request of language line services or interpreter services 24 hours a day, 7 days a week. And as you can see, all calls are answered within 30 seconds. We follow the normal guidelines and ensure that those standards are upheld so that a member never receives any busy signal or provider if they may call. What we found is members or providers on the behalf of a member who need immediate assistance may call the line, choose member, and then choose more on the phone tree. And then you do have to wait until number 8 on the list after you choose more in order to click or choose the language service option. At that point, our member services receives the request, and then warm transfers or continues with the vendor who provides our language services to ensure that they're on the call with the member and the provider. And as soon as that kind of dialogue is facilitated to promote the exchange of information, then our member services representative would disconnect so that the language line vendor would be on the phone then with the provider and the member. This is our standard protocol. We, looked at how to move, the language service option up on the phone tree, and some other ways that might improve the experience. But currently, this is the protocol or the process that we use. Any questions?
No, thank you.
Mm-hmm.
I was just saying I'm testing it right now, and I'd never get that
If you're
member
a Sky
option.
member, say yes. Otherwise, say no.
So the option to choose member, like I was on it for a couple of minutes, and there's lots of options on the phone tree, but member wasn't an option. So I don't know if you want to call back through. I'd love to have, like, if you would call back through the line, and maybe I missed something, but there wasn't like a member. There was like, if you're a provider, press star, but then you end up in another phone tree. And then it did ask me if I was a Sky member, but it didn't ask me if I was a member. So
Okay.
it's
Okay. We can definitely review that and get back to the group.
Thank you, Julia.
Hi, yes, this is Danita Coker from DMS, Equity and Determinants of Health Branch. Susan, you mentioned that you all had looked at moving the language option up on the phone tree. What barriers did you face with moving it up from number 8?
Cost and time. So it's quite a process. We haven't decided not to do that, but those are some of the barriers and opportunities that we found when we were researching this. So in order to, it's a work order and then a technician and then an IT. So several kind of hoops to start working through, and a wait time in order to do that, but something that the plan is definitely entertaining.
Jake has his hand raised.
Yeah, this is Jake Archibald, Health Equity Consultant with United Healthcare. I was just going to say I'd be happy to go next if we're going to continue presentations on the interpreter line.
Sure.
Can I share my screen?
Yes, you may. Just 1 second.
Awesome. Thank you.
Okay, you should be good to go.
Okay, great. Thanks so much. My interpreter information or presentation is in with our grievance stuff as well. Can you guys see my screen?
Yes.
Yeah.
Okay, great. So of course, both the member and the provider can call to request interpreter services. From the member side of things, we do have the member services number on the back of all of our ID cards where members can call. At that point, they will get an interactive voice response. It'll ask the member the reason for their call, and at that time, members can say interpreter, and that they'll be transferred to the language line. They can also immediately just press 3, and that'll take them to a Spanish interpreter. For providers, pretty much the same process, except they are going, after you call that 1888 number, they are going to ask you for a client ID number, date, time, location. And then the provider services line can also be called directly at 1866, and then you can see the rest of the number, of course. The member or provider can also request an on-site interpreter for appointments, but that has to be done, unfortunately, 3 to 5 days in advance. Any questions?
Can you tell me again on the provider side, the two numbers, so the bottom number is just provider services and the top one is directly to language line?
Yes.
I believe in the presentation we had been sent maybe before the last TAC or after the one before that even. I think you guys had said you had tested how long it takes to get through the phone tree.
I'm not aware of that. I didn't provide that information, but I can definitely find out and report back.
Schedule, modify, or check the
There was one that had said that they had tested the time. I thought it had been United, but I could be wrong with that.
Yeah, I will check and find out for you.
I think Julie is currently testing it.
Awesome.
Okay. Who else do we have? That way they can go ahead and at least get theirs set up.
Hi,
for
this
sharing.
is Darren Levitz with WellCare. I'm happy to bat third.
If you have anything to share, you should be able to do that.
Okay, do I need to wait for my friends from United to
Yes.
unshare?
Yeah, there you
I
go.
can present theirs, but they probably wouldn't like that. All right, give me just a minute here. All right. Okay, pardon me, let me get to our grievance slides here. Go full screen. Hopefully you guys can see that. Okay, so just a quick overview of something that we want to share. First of all, that according to the Medicaid contract and according to the law, just a reminder that providers are required to provide interpreter services to members. I think that's something that wasn't necessarily brought out to some of our prior conversations. However, when that's not possible to provide those services, WellCare is more than happy to help identify those enrollees who have linguistic barriers. And we can provide a number of different interpreter solutions, of course, at no cost. Those services include verbal translation for different languages, those with limited English proficiency, whether that is because English is not a primary language, or just those who may not have a mastery of the English language, even if it is their primary language. We also have sign language for those that are hearing impaired or have no hearing. We contract through local providers.
Is it too loud for you?
Can everybody hear okay? I'll continue. WellCare can also, I said, as I'm sure many of the other MCOs can do the same, provide with locally contracted providers for in-person translation services. We can also provide large print format of services for those that may be visually impaired. One thing I also want to bring out is an important distinction between those that are non-emergent and those that are emergent. For not emergent needs, we ask that interpreters are notified either through the provider or our members, and information is available through our website, amongst other places, to get that information. Give us up to 5 business days to provide an interpreter on site. As we've discussed, that's not always a reasonable request, because emergencies do happen, in which case they can call through our customer service, which will patch them directly through our translation service. And we can have somebody that is available to assist via the phone. And there's a QR code that we do share with our provider network that hopefully is posted in each room, so that can be contacted and have that person ready when the physician is ready to see the member. On our next slide, I think it's also helpful to get a perspective of the breadth and depth and the frequency of our translation request. As you see within Kentucky, Spanish is the dominant language, coming right in a little over for phone translation, and just a little under 70% for other translations. And then for on-site, there's ASL. And after that, it tapers off pretty quickly to very, very few requests. And I say that just to keep a realistic perspective of translators that are available. We do provide all those on site and on the phone, but sometimes it may take a little bit of time to patch that through, because with some of these languages, there's such a low need for those. While we can definitely contract that, we don't have someone 24/7 waiting by that phone. Right at that moment, it may take a minute or two to contact them. So that shows appropriate level of service for the needs requested. And that wraps up our presentation.
Go back to the QR code.
Oh, I'm so sorry. I stopped sharing too soon. Let me go back to that.
And thank you for reiterating the requirement for interpretive services. I think we had talked about that initially, but it's always good to reiterate that. The access, I think the reason we're talking about it in this particular TAC is when you look at equity issues for non-English speaking or people, language access in healthcare obviously is crucial in life and death. And so I think that's why we're speaking about it so strongly in this TAC, because if you don't need it, you don't need it, and all goes well. But if you need it, it's an emergency, and so that's why we want families to have access without question. And what happens at high volume offices, we figure it out, right? We just get it done. But say they go to an office, dermatology, that doesn't typically have one, but the dermatologist needs to tell the person that they have a serious cancer. We want to make it so easy for them to be able to get an interpreter and tell that family what they need without a pause, right? Not, oh gosh, we're going to have to find somebody. We'll call them next Thursday and let them know. Like, we wanted this to be so seamless that it's just, nobody even has to think about it. And so that's why we're speaking about it, particularly in this TAC.
Well said.
This is David with Passport. I can go next.
Okay. Here. Stop sharing. Thank you.
I don't know. How do I share?
You should be able to now.
If I hit share screen. Oh, here we go.
There you go.
Can you see it?
Yes, we can.
Okay. Okay. Interpreter services for Passport. Technically, assisting interpreter services member and providers can access interpreter services through Global via two methods: by calling Passport Molina Healthcare member or provider contact center through case management. Interpreter services are available for telephonic and face-to-face services. When an agent basically gets a call in, agent initiates the interpreter request and coordinates with Globo. For telephonic interpreter services, agents set up conference calls with Globo for immediate telephonic connection. For face-to-face services, agents collect the appointment detail and request language. Normally, these are done from case management. Case management is the ones that normally set up those. They contact our team leads, and the team leads basically goes into the Global system and sets up the request. Providers will receive confirmation of the schedule and the interpreter services via email. Telephonic interpreter process: members and provider call member and provider services to request interpreter. Agent determines the required language. Agent initiates a three-way conference call with the interpreter for Globo. Agents provide a call script to the interpreter for effective communication with the member. Verify, basically HIPAA, making sure that they're verifying who they are. Interpreter facilitates communication between the agents and the member and the provider, the member and or the provider. Interpreter assist call is it's documented and the call's been completed. For face-to-face, agents receive interpreter requests for face-to-face services. Agents collect appointment detail and request language. Lead agent schedules the interpreter request via Global website. Provider and our member receives confirmation via email. If a in-person interpreter is not available, video services are considered as an alternative. Global communicates with Passport for video service feasibility. Technically, handing interpreter for grievances. Grievances are always done. Technically, the member will contact Global. They basically get the information if it's a grievance. And I know Carrie will probably go over the grievance process. But the information is documented and it's forwarded over. There was a typo here. It's basically sent over to A&G for handling of a grievance. Then this right here, this is from January 2023 to June 2023. It just basically shows the total number of calls we've received for telephonic, video conferencing, and then in person. Utilization for January 2023 to June 2023. And that is it.
Are those telephonic utilization, is that for Passport employees trying to communicate, or is that external people trying to access the interpreter lines?
That is probably basically us communicating with Global with a member on the phone, but I can verify that because this information is sent to me so I can get more details. Is find out. I know that I think you're in our TMAC meetings when I report out, and those numbers are normally ones that we're setting up when the member contacts us, and basically we connect to Globo for their interpreter services.
Right. Yeah, that would make more sense on those numbers because you know that there are a lot more patient visits than those numbers listed. Yeah. Thanks.
Right. Mm-hmm.
And I didn't see the direct phone number. Was that in your first slide? I missed that.
No, it's not on there, but the direct number is, well, we don't have a direct number. Basically, it's the number is 1-844-311-9777. That's the number that we reach out to contact Global.
Okay. Was the last MCO for interpreter services?
I believe so. And could I ask the MCOs to please email your presentations to either Aaron Bickers or me?
Well, Kara's the only one we need, Kelly.
Okay, thank you.
So a couple of questions. As is with how it's set up, whenever someone is signing up for like their Medicare coverage, and they list like primary language or Spanish or a different language, is there anything that they can put where if they would like to request an interpreter for future visits? Like, do they have to reach out for each specific visit, or is there a way that whenever the MCO sees that someone has set up an appointment for, you know, a month from now, if they've previously requested that they would like to have interpreters available for their visits, that is someone reaching out to see, you know, do they need an interpreter to go with them to that appointment, or is it on the member themselves to make sure that they've called ahead of time?
I'm not sure the MCO has purview into each appointment that the member sets up, since it's usually done at the provider office level. So if the MCO assists the provider, the member in finding that, I think that's an excellent suggestion. Otherwise, I do think that either the member or the provider will need to contact the MCO in order to make those arrangements.
Yeah, at the time. There's not any way to like automatically have that process. Okay. At the last meeting, Julia had asked, I believe Angie, if there was like a specific person within Medicaid that's looking into like being a point person for language access, or to kind of have a focus of trying to streamline these things and make sure that these processes are being reviewed. I didn't know if that was something that they had discussed after the last meeting.
I'm sorry, were you asking me?
Or if someone else was part of that conversation. Yeah, basically she was asking if there was a point person for language access within DMS currently.
I do not know the answer to that question. Danita, do you?
For language access specifically
within Medicaid?
Regarding processes, I want to make sure I'm clear what you're asking.
Is there anyone that looks into
complaints? Yes.
Yeah, I'm sure.
If it's complaints, yes, definitely we have that with our health plan oversight. But are you asking specific questions?
I think the question really is like, it would be nice to be proactive about language access instead of more reactive. And so even though, you know, we know that the MCOs have on all their websites and information in their member benefits and things like that, there's a lot of information out there that clearly isn't getting to a lot of members and a lot of providers. And so it might be more beneficial for access and equity if we took a more proactive approach and really looked at it from an isolated quality issue, language access, versus it being embedded maybe in some other type of indicator. Because I think there are definitely a lot more conversations beyond that what we have had here at the meetings that will improve access and improve quality and improve equity around people who are seeking care in a language other than English.
Well, I can let Danita speak to this further, but yes, and as a high level, Medicaid is looking into that on how it can be better communicated.
Are there surveys or anything like that that are done for the members that do access it, asking how like the services can be improved?
So right now, Dr. Burke, we have not initiated surveys. So right now we're just initiating our first strategies to try to address the equity issue and identify specific barriers and how DMS can improve moving forward. So we're working with the MCOs. There has been specific requests from other TACs regarding interpreter services as well. So one of the strategies that has been requested and that we believe is reasonable is that we have asked the TACs to create a one-pager that can be utilized as an educational resource for not only providers, but also for the enrollees, that outlines each MCO's process for obtaining the interpreter services. And as was pointed out in the WellCare demonstration, also what those requirements are here in Kentucky. So we want that to be easily and readily available, again, to the providers and the enrollees. And then we've also requested that MCOs provide us with what their strategies might be for outreach and education to ensure that, this information is relayed clearly, as you mentioned, to maybe some of those smaller providers' offices that might not have this information. So how will we get this information out to them as well? So we're working to try to address this, and then we're open again to your feedback, and we will keep you all posted on what we find out as we move along with this process. So did that provide you with what you needed?
Yeah.
Okay.
Yeah, again, just trying to figure out.
And yes, as it is a priority. It is something that we are working on.
And what I might also add to that, since we have the MCO representatives, is that we've also had specific feedback from ASL. So we want to make sure that that is inclusive with all these strategies that we're trying to roll out to the providers and to our Medicaid enrollees. So we're trying to be cognitive of all those barriers and try to address those.
Good. There was a question that Juliet asked last time about like which are any of the interpreter services to the MCOs. Is it look like a lot of them are just like 7 to 7 Monday through Friday? Is there anything that's looking into like weekends or evenings, like later in the day, like 24/7 coverage? Or is that more of, as you had said, like healthcare facilities should have interpreter services available as well? If it's outside those hours, does it fall outside the MCO's like purview? Are they looking to expand in more hours for interpreter coverage?
So I think that is the question that the MCOs might better answer. My request is still pending, so I will get additional information from them by the end of this month. So they may be able to jump in and let you know what they have available in regards to the hours.
Okay. All right, we can go on to the grievance processes. I believe last time only Anthem had presented theirs, so we'll have everyone else today. Whoever wants to go first.
This is Susan again. I can start us off in alphabetical order.
Thanks.
Share. Okay. Awesome. Okay, so again, we kept ours as brief as possible. I know it's a full agenda today. All of this information is also available on our website and our member handbook. We issue member and provider newsletters in the provider handbook. So, according to our standards and requirements, this information is readily available to our members and also to providers. I tried to also show you all the language that we use in those documents and on our website to ensure that we, relay as much of a helpful and open, story to our members as possible. As you can see here, we explain what is defined as a grievance, what is defined as an appeal, and then finally we provide details on what the grievance process is, what the appeals process is, the website, member handbook, newsletters, and then the ability to call member services are all places that members are able to locate this information, as I mentioned. And we ensure that we provide information on how to file grievance and appeal, how to choose someone to act as a representative for the member, what timelines to expect, how to call, and also file an appeal in writing, the notification process, any worries about outcomes, and how we relay that information, and of course would not reciprocate any negativity with a member who engages in the process. The only other unique note that I want to share, I did not put it on the slide because it's unique to our SCI population. We also have an ombudsman role. Our SCI inquiry coordinator is a contract required role in the SCI program, which serves, of course, our system involved youth. And that role, Jesse Kane has been our inquiry coordinator since the inception of SCI. Part of his job also is to ensure members and providers understand our grievance and appeals process, and if they need any support, that those SCI members can engage with Jesse, and he can walk them through that process. He has a lane, and then grievance and appeals has a lane, so that the process, remains, standard operating, and the grievance and appeals process remains in its integrity. But we do have an advocate who can help members and the SCI population walk through the process. And that's all we had.
Thank you.
Sure. Any questions?
No, for the number, did you say that is through like
Our
the line that
members,
you guys
our
use?
member services. Yeah.
That was my question. Thank you.
Mm-hmm. We try to provide just a simple number that then the member or provider can be warm transferred.
Whoever MCO would like to go next.
Sure. This is Jake from United. I'd be happy to go next.
Sure.
Can you guys see my screen?
Yes.
Yeah. Awesome. So again, to try to be brief, going to skip the what is a member grievance. I think we all know that. Of course, there's two ways that members can file grievances, either by telephone or in writing. Once the grievance is received, within 5 days of receiving it, we will inform the member, of course, that we got it. And then we will review their grievance and inform them how it will be resolved within 30 days. Of course, if the member is not satisfied with the outcome of that, they can contact our Medicaid Managed Care Ombudsman program. We do have an ombudsman here local to Kentucky who can help with that. As far as provider grievances go, they too can do it two ways, by phone or in writing, or they can also use the provider portal at this URL to submit a grievance as well. The process after a provider files a grievance is similar to that of a member, in that they'll receive a notification of receipt of the grievance within 5 business days from the date that we receive the grievance. And then United will work to resolve the grievance within 30 calendar days from the date we receive it. There are times where we need additional time to investigate, and a letter will be sent requesting a 14-day extension. And then United will inform the provider and or the member of the outcome of the grievance, of course, within 30 days, unless we file the 14-day extension. And that is it. Any questions?
Can we find the phone numbers on the back of their cards, or do we have to write down the phone numbers that you provided on your presentation?
Yeah, you can find them in the provider portal, or on the
Portal.
back of the cards as well. Yes.
Thank you.
All right, hi, this is Darren with WellCare again, and I'm happy to share our process as well. Make that a little bit larger. Pardon me. Okay, our process begins when a member or member's authorized rep can file a grievance, and they can do that either via phone or in writing. You see those numbers and address there. Upon receiving a grievance, we initially do some triage to initiate and determine validity, category, and the severity of the grievance. We will acknowledge the grievance to the member into with a DMS approved template, and we do that within absolutely no later than 5 business days. At that point, we have assigned it to a grievance coordinator who will begin outreach to the member to research and investigate the complaint with the goal of resolving it. At that point, we also collaborate with our providers, external vendors, and internal departments to figure out how we're going to resolve that grievance. We will resolve the grievance and notify the member and or the representative within 30 calendar days, utilizing state-approved letter templates. If a member should be dissatisfied with how the grievance was handled, they may file a further complaint with the Medicaid Managed Care Ombudsman's Office at the Cabinet for Health and Family Services. And you see those different ways of communicating to that entity. For tracking, reporting, analyzing, auditing grievances, we track each one from receipt all the way through resolution by capturing the member's name, date of contact, the nature of the grievance category, the provider ID when that's applicable, and the disposition, which we all maintain all that information for at least 10 years. We categorize the grievances in order to identify trends and opportunities for MCO improvement. We generate internal reports, including daily, as well as issue monthly reports to DMS. We analyze member grievances data to the root cause. We provide those grievance metrics and report those to the MAC, as well as the QIC. These committees discuss trends, processing areas, barriers, and opportunities to create action plans. We also document our analysis in the quality improvement work plan. We do that on a quarterly basis. We share any analysis and finding with our provider relations team, which who can also outreach to providers as needed. And lastly, we audit our grievance resolution letters, pulling random samples and check and make sure that all issues are resolved as should be. And that is our overview of how we process a grievance and how we track, report, analyze, and audit them.
I appreciate you showing the ladder about how you guys actually handled reviewing the grievances that do come in.
Thank you very much.
Hi, this is Leslie Clemens with Humana. I'm happy to share our processes.
Leslie, you should be able to share your screen now if you need to.
Thank you so much. Let me know when you can see what I believe. Nope, I think you're looking at the wrong thing, aren't you? Now, are you looking at my email or are you looking at our grievance process?
Think we got it now.
All right, nobody wants to see that email. It's not fun. All right. Hi, everybody. I'm Leslie Clements. I'm the Director of Equitable Population Health at Humana. And very similar processes for grievance and appeals for us at Humana that you've seen from some of the other MCOs today. All of this information is made available on our website. We also have it prominently displayed in our enrollee handbook to make it easy for folks. And the phone number that we allow folks to call in is the same member services phone number that we use for just about everything else to make it easy. So I've got that number on the bottom of the slide for you, as well as the address. The way that we process our grievances, those can be filed verbally or in writing, either by our enrollee, somebody who represents the enrollee, or a provider on behalf of the member. And that can happen within 60 calendar days of the incident. And if it is something that's filed by the enrollee's representative or a provider on behalf of that enrollee, then we want to make sure that that person has the authority to do so with a POA or an AOR or some other form that is signed by the member, giving that person legal permission. Once we get the grievance at Humana, we do send an acknowledgement letter within 5 days so that they know that, hey, we got your request, we're checking it out, and we will be sure to give you a response within 30 days. At that point, we've got a specialist who researches the issue. They reach out to any business partners at Humana, such as quality management or provider relations or our nurse advice line, depending on who might be able to support. And then once we have resolved the issue, we make sure to send that resolution letter to the enrollee, letting them know what steps were taken to resolve the issue. And we too also have periodic audits to make sure that we're following these processes consistently. So that is our grievance process. Our appeals process, again, this is all highlighted on our website and in the enrollee handbook. You can see the contact information at the bottom of the page. And in this case, we can do both standard and expedited appeals. Those can be filed verbally or in writing by, again, the enrollee, someone to represent the enrollee, or a provider on behalf of the member within 60 calendar days of the notice. And again, we want to just make sure that it is someone who does have the authority to represent the member. So we do request a POA or an AOR or some other form as needed. Once we get that appeal, if it's a standard appeal, we will acknowledge, hey, we got it. We're checking it out. We're going to let you know what the response is within 30 days of receipt. If it's an expedited appeal, we want to really do that quickly. So we don't have a formal acknowledgement, but we do make sure that we resolve those expedited appeals within 72 hours of receiving them. In every case, we have a specialist, again, that researches the issue. They reach out to all the appropriate business partners across Humana. Might be the regional medical director, might be the claims rework unit, whomever's needed to make sure that we're able to get this done quickly. And once we've made a determination, again, we send a resolution letter to the enrollee to let them know the outcome of the appeal. And we also audit these periodically as well. Any questions? Thank you.
Thank you.
Hi, this is Carrie Elder for Passport. I can present next.
Great.
Hey, Carrie, I'm trying to make you a co-host.
Okay.
Hang on, give me just a second. My computer's acting up today. Okay, you should be good to go.
Okay. No, just 1 second. I seem to be having issues as well. Just 1 second here. Okay. Let me know when you can see my screen.
We see it.
Okay. Let me make it a little bigger. Okay, Okay, so like everyone else has said, I won't go through what is considered a member grievance. We've already talked about that. Our definition is pretty much the same. And the methods of receipt, we do allow, of course, verbal, and that is through the contact center at their the main number, and it will be routed then to appeals and grievances in real time. And a member can also submit a written complaint through any of the following methods. They can fax it, they can mail it, or they can email us at our external email that is listed there. And just walking through how we then work the grievance. Once it is received in appeals and grievances, it's reviewed and entered into our documentation system. We make an initial outreach by phone and also written with a written letter within 5 days of receiving the grievance. During our initial call, we discuss the issue with the member and let them know what to expect. And after our initial call, we research the member's issue and attempt to find a resolution. And we have 30 days from the date of receipt to resolve the member's complaint. And how do we resolve complaints? Here's some examples of some things that we would do. If the member is being balance billed, we'll view the claim, contact the provider, advise how to file a claim appeal, advise the member that they're not responsible, confirm with the provider that they'll cease billing the member. Or if the member is asking to disenroll, we will advise the member of the criteria to disenroll outside of open enrollment and help the member solve the issue if the request does not meet the criteria. And then if the member reports an issue with their provider, we'll speak to the provider, attempt to resolve the issue, or reach out to their provider representative if more intervention is required. We'll also offer the member to find them a different provider if it is just something that cannot be resolved between the two of them. We'll help the member find a different provider. If the complaint is something that's outside of our scope for an outside agency, we'll help the member get in touch with the outside agencies that they need to speak with about their issue that is not part of their passport. And then here are some types of grievances that are kind of our internal definitions of how we would break down different types of grievances. I won't go through each one, but just to point out a couple. If we receive a complaint from a provider or someone that's not the member, but we don't have an appointment of representative for them, we will contact them, let them know that it's needed, offer to email it to them or to fax it to them to get it to them so that we can then go ahead and work on their issue. I will also point out that pharmacy grievances, if we have complaints for infusion medications, coordination of benefits, or reimbursement, then we would handle those complaints for the member, and all others related directly to receiving their medication would go to MedImpact. If we receive a complaint that has also an appeal in the request, then we will separate it out into 2 separate cases for an appeal and a grievance so that the appeal can be addressed directly. For quality of care, if we receive a quality of care issue that is that meets the level that is accepted by our quality department, we then would work with the member without divulging any details of the way it is being addressed with the provider, to let them know that their concern is taken seriously and that it has been referred to quality, but that our part of the grievance will then end. So we help them find a resolution as much as possible without giving those details. And that is the end of my presentation. Any questions?
Nope, not for me. Thank you so much. I mean, it seems like most of the MCOs have somewhat similar grievance processes. If nothing else, I think it's nice to review so the different MCOs can see the differences and if there's anything that the different MCOs do and that they would maybe want to implement themselves. If they find that some other process seems more intuitive or better for patients, then that's a good thing if they decide to implement something. I don't know if any other TAC members have any specific thoughts. If not, we can go on to the next part. Anything regarding the GARE tool?
Yes.
Excellent.
And I know you've been anxiously waiting for this. Danita will be going over how all that works. I apologize for the delay.
It's fine. It's been 2023.
So can I share my screen?
Absolutely. Give me just a second. Okay, you should be good to go.
Okay. And you all see the presentation.
Yes.
All right. Give me just a second. Let me get situated. I'm going to turn off my camera as I go through this. What I'm going to do is just provide a very high level overview of equity tools. Not going to give a demonstration of a GARE tool that we have completed, but just provide to you, the flexibility, talk about what the flexibility of what GARE tools are and how they can be adaptable. We'll talk about how DMS has utilized the tools in our practices and just talk really briefly about the fidelity of them, just basically what we have found. And of course, the slides are available at the end. And I have included in your resources some completed GARE tools that other states have completed on issues that they have found relevant for them. So the GARE tool that we are using is from the Government Alliance on Racial Equity. And so what you'll find is if you were to just Google equity tools, that there are multiple toolkits that can be adaptable. So we selected this toolkit, the GARE toolkit, and from the authors of this toolkit, they say that the purpose of them is to reduce racial inequities and to improve the success for all groups. This toolkit specifically is a joint project of Race Forward, and I think most of us are familiar with that group, and also the Haas Institute for a Fair and Inclusive Society. This toolkit is easily adaptable, it's very flexible, and it can be utilized across agencies without lots of in-depth training, and you can use this with limited resources. So, we've been able to train our staff and also train our MCOs on this as well. We set a goal for DMS actually to implement and train all of our staff on the GARE tool by December 31st of 2022. We completed that goal, and again, we extended that goal to our MCOs. The MCOs have created GARE tools for each of their organizations, and they were also trained in a workshop, in a work group, so that they are familiar with the process and they have rolled this out as well. When you're looking at the bear tool, I'm sorry, the GARE tool, thinking about, you know, what we said about reducing barriers and making things equitable across the board. Of course, this is something that we've all seen, this slide. So what we hope to do is just remove barriers and to create equitable access by using this tool. So it's basically taking a look at your procedures, your processes, those standard operating procedures that you might have in place, and just taking a view of any historical barriers that might be in place, any systemic barriers that you might notice, and then the steps that we'll use to do that. It's just a quick 6-step framework. And so you're looking at that just to see how you can better remove any barriers to create that equitable access. So this is just a picture of the framework. And this is the overall goal or objective of what you hope to do when you're creating this work with the GARE tool. You know, again, we've mentioned the word being proactive. So, you know, we're proactively seeking what we can do to eliminate these inequities. And at the end of the steps, what we hope to do is just to develop strategies that are going to advance racial equity and to mitigate any unintended negative consequences, because there's always the opportunity that when we introduce proposals or initiatives or ideas into the community, that there may be some unintended negative impacts. So utilization of these equity tools gives us the opportunity to look at those proposals for any potential unintended consequences. Two of the common questions that we receive when we're talking about the GARE tool is, when do I use this tool and how do I use this tool? So the answer to those questions is that you would use this tool early in the beginning of any proposal, idea, or any initiative that you have. Before you start rolling that out, you want to think about implementing this GARE tool. So in other words, you wouldn't want to complete all your work for creating this initiative, have this great idea, and then run it through the GARE tool afterwards. So you want this GARE tool to be a part of the process as you roll it out. And then you want to do that inclusively by including those members of the community that have different perspectives and lived experiences, so that you can gain that feedback as you create your initiatives or proposal. So these are the 6 steps that are involved with creating the GARE tool. If an organization or an entity wanted to just do a basic and fundamental equity tool review, these 6 steps would serve process. But DMS, we have included within our GARE tool, there are additional subsets of questions beneath these initial 6 questions that help you kind of dive in a bit further and examine within more detail how your proposal, initiative, idea, or budget decisions might be more feasible, realistic, and how you can produce more measurable outcomes. So in step 1 of the GARE tool, your very first question that you want to answer is, you know, what exactly is my policy, the program, the practice, budget decision, or idea that, or initiative that you want to consider. So you want to be very exact with this and think about your results for this. I have an example here. Whenever you create your GARE tool, you utilize your GARE tool, you want to use this along with an action plan. So what we use ours with is our racial equity action plan. So our racial equity action plan holds us accountable to any proposal that we have. So we're able to measure our outcomes. We're able to see our actions and the steps that we take. we also know the cadence of when we're going to check in. So do we have a quarterly check-in for this goal? And how are we going to check this data? So whenever you create your proposal idea, you should also have that plan of action to go along with that. One section that's important in the equity tool is that you want to think about who is going to be impacted by your proposal, specifically as it relates to racial equity. On this page, there is the opportunity to select more than one of these categories, but it's highly unlikely that you should select all of these. So on this page, you might want to go back to step one and really look at your proposal to see specifically how your proposal will impact the group that you select and how you can measure the outcomes for that specific group. You want to think about intersectionality, how individuals will be impacted. We know for many proposals or initiatives that they're all going to, many of them will have overlapping things like the SDOH needs. So you want to think about your overarching goal when you select who your racial equity will impact. If it's going to impact transportation overall, then that's what you would select. But if you're looking for something that's specifically around children and youth, then you would select that. You would know that possibly food access, maybe transportation would also be included, but what do you want to measure? So that's how you would kind of look at that section. And so talking about measurements, you want to think about your data. When you're looking at your data, you may not always have the data that you need, but you want to make sure that you're looking at your local, state, and your national resources when you begin to pull your data to determine, whatever patterns that you recognize and assess the inequities or disparities across those specific groups that you've selected in the earlier steps. If you find that there are data gaps and you feel like that there's not a realistic way to measure your outcomes, then you might want to revisit your proposal idea. But another avenue is also the part of engagement with communities. So if you do find that there are data gaps, then there's also the opportunity for your next step, which is one of the most vital steps, is that community engagement piece. So in creating your proposals, we're all familiar with the phrase, nothing about us without us. So this is the very important step of including those communities in the process that can sort of help us better identify what's important to the community, how this proposal might impact them, if there may be any negative impacts on what our ideas are. So, some of those things that they might answer for us are, what are the values in their community, the views from the religious institutions, what languages, how is this proposal or initiative, is it inclusive of those languages, some of those things that we're talking about today? And another thing that's important is really to find out if this proposal or initiative might further impact any traumatic or crisis events that the community might have already experienced. So then you want to talk about what are your strategies for advancing your equity. And so again, your community is helpful in this process in obtaining any additional information. It also helps you when you're beginning to evaluate your overall effectiveness of the impact of the proposal. So when this is where you're going to do your outcomes and your measurements. Some of the questions you can ask yourself in this process is, what did you further educate? Was there education obtained? Was there anything learned from your proposal that helped to improve or make any changes? So in this phase of your equity tool, you're looking at your implementation plan just to see for your organization or entity if your plan is it realistic? Do you have the funds, the personnel? And then this is where you can take those opportunities to explore further. You can look at your budget to see if there's some things that you might need to change in your budget, or you might also look for additional funding opportunities to support your proposal. Always throughout this equity tool, there's always the opportunity, if you have to answer negatively to any of these questions, there's always the opportunity for you to just go back to your initial step and just look at that first proposal and maybe streamline it, revise it as needed. And then we talk about the accountability of it. And then I use the example of how we're held accountable by using our racial equity action plan. You know, some of the questions that you would ask yourself when you're doing your performance measures is, you know, questions about how much did we do? How well was the quality of the work that we done? Did we make the situation better off? And, you know, if there were negative impacts, what did we do to mitigate those negative unintended consequences? How did we get our messaging out to result in an increase of the knowledge about what we are doing to help make a positive impact as far as reducing racial inequities? And then using both our interdisciplinary teams as well as our interprofessional teams to look at our goals that are intended to help us keep the momentum moving forward. So if we've made a positive impact, what can we do to sustain these efforts? So this is, again, goes back to that question of how often will you use this tool? So this would be a time when you're looking at your outcomes and looking at that data to see what your results are. You would use your teams here to see, you know, what do we do that was positive to help us keep this positive impact going? What can we do to keep that momentum moving forward? And if you did have, if you do notice that you don't have the results that you were looking for, then this is also another time that you can look at streamlining or revising standard operation procedures or creating some type of new initiative or proposal. And so just in concluding, where these equity tools first initiated was, of course, with the equity pillar that was initiated from the federal equity order. There were 200 federal agencies that were required to review their agencies for equity. Each one of those agencies, because they do something very different for the federal government, had different tools or different ways to measure equity. So that is why there has not been one standardized equity tool that has been approved to be used across the board. So that answers, you know, one of those questions that comes up earlier about those 6 main questions at the beginning and those subsets of questions. They can be tweaked to meet your organization or entity needs. But the overall findings were that the equity tools do support the need for measuring equity, and it's important to assess equity within the organizations. So that is it in short, sweet, high-level overview. Again, these are the resources that I have used with pulling this information together, and some of the data points that we use as we look through, you know, equity, measuring equity. So I've provided those, and then also those examples of some of those that are completed. by other states. And these are some downloadable equity toolkits, just some examples for you to take a look at and just to see that there are different ones available. So these slides are available for you, and that is the end of what I have available.
Thank you. With this geared so that you guys have implemented, how long has it been that you've been using this for initiatives? Has it just been within the past year when you guys have been doing new things, or was this already something that had been ongoing previously?
So it has been ongoing previously, and I think I saw Jody Allen on here. I actually took this work over from Jody.
About the GARE tool, everyone in DMS was asked to be trained and trained all of their areas and to complete a GARE tool by December of 2022. So this has been up and running, and all divisions have known how to use it and been charged with using this with their initiatives this full year.
Yeah. So all new initiatives within the past year have been using this type of framework.
Yes, correct.
Great.
Yeah.
What have you guys seen as far as what things are you doing now that you feel like you may have not been doing adequately before that you feel like actually might provide more benefit? Obviously, you're taking a much more broad view, it would seem.
And I would say Danita definitely has the more broad view across Medicaid at this point with that, but within the behavioral health initiatives division, I can tell you that definitely realizing that our data needs work is something that we have seen. Also, including individuals with lived experience is something that I know has definitely come to light for us. Being more intentional about that and being more intentional about involving community. So those are three things that I can think of just within the behavioral health initiatives team by using the GARE tool that have really come to light for us.
Good. Well, hopefully as new initiatives and things are pushed out that are using a tool like this, we'll see positive benefits on health disparities.
Definitely.
Yes, as Jody mentioned, all of the departments within Medicaid were trained on this tool, utilizing this tool. And as Jody also mentioned, we know that our reports need to be improved when it comes to identifying racial equity, health equity issues. So we've been reviewing all of those with our MCOs to include those, ensure that those are being addressed, and so that we can adequately follow and focus on those areas which are not.
Are you guys actively looking at past initiatives that may have neglected addressing these types of questions to see if there's any initiatives that you could, I guess,
I think everything that we're doing is including the equity lens. With the reorganization of the department to include an equity and determinants of health branch, that has helped expand that. And and the development of this TAC has been very helpful in helping us to also ensure that we are focusing on the right initiatives as well.
And I would definitely say that even past policy we've used, I know the GARE tool has been used with some of Medicaid policy regulations and some past initiatives. Just in my work in collaboration with other divisions, I know that there have been things. Not every single thing, of course. Medicaid is just such a huge beast, but I think that there have been some policy, especially things that are really specific to equity, or that could potentially be a huge barrier. So I know that there have been past initiatives and past policy and regulation that have been reviewed.
Yeah. And I think that's a good point though, right? Like before it was, yes, obviously these issues deal with equity, and so we'll view it through that lens, but looking at everything through that lens, that way you're not missing the areas that you didn't think it would have an impact on.
And as you know, COVID brought to light a lot of these inequities as well. So having to go back and look at what those were and how we address them moving forward. Danita, I'll let you add any other additional of the work that you've done specifically.
I'll just say we're through our racial equity core team. That's another way that the GARE tool and our racial equity action plans are they do hold us accountable to how we keep the pulse on equity for each of our divisions. Again, each of our divisions have a lead liaison for the racial equity core team. And so that person is sort of the mediator that sort of leads equity issues for their division, any type of education that needs to be shared within their division, any type of equity goals, those things are shared. And also, again, to stay in line with the accountability as far as outcomes and measurements for that action plan. Each division has set their own specific goals that are related to the work that they do. So again, we report on those quarterly to our commissioners and to the secretary as well. So we do have accountability for that. So those are additional steps that we take to support our equity goals.
Moving on to updates. Is there any MIC updates since our last meeting?
Jordan, I just had a quick question on the
Yeah.
other topic.
Yeah.
One is there a state or a Medicaid program that, or a couple that are really aspirational, have really advanced in this work that you all are looking at?
Well, everything is aspirational because we know we're behind. And so, just a lot of the things that you all brought up, transportation issues, which we went through a meeting 2 ago, the access of care, being able to get the interpreter services. So like I said, a lot of that, it's been brought up in this meeting that we're making sure that we're focusing on, and other areas in which there's a lot to work on. And so, and they're all as important as the other. So we're trying to, through this TAC and through what we're seeing and reviewing with our MCOs on how to best address it holistically as well.
And are there any particular states, like is Arizona doing having really innovative work, or Minnesota? Is there any state that you feel is something that we can look at?
We could look a little bit further into that for you, and we do have with CMS, or the National Association of Medicaid Directors, a health equity meeting with them on a monthly basis, and we kind of talk about what other states are doing in that arena as well. So
it's always fun to hear. It's for us to hear other ideas, and so that would be interesting. And then, along the way, we've really talked about the gaps in data that we have and how you all are really working on that. So, with those not being required reportable fields. And so any updates at the next meeting, or if you have any now, on ways you all are trying to strategize to get the data that you want?
Oh, we're getting a new system hopefully in the next year and a half. So, yes, what Jody just put in the Medicaid Innovative Collaborative is a cohort that we have worked with, and transportation and food inequities and how to address those. California is doing in lieu of services. We're working on a social determinants of health dashboard, which is going to include, getting all of the different issues onto one area so that we can really help with the focus of that as well. I'm doing all the talking, Danita. You've got all the answers, so I'm gonna turn it over to you.
No. I was just going to add that Mass Health they have been leading some of the work on disaggregating data and doing stratified data. From what I've been researching on them, they've been leading some of this work since 2017. So myself and Letha with Population Health, we've sat in on several of their webinars just to see what their strategies have been and just follow their white papers and their reports to see, you know, what the data is. So they have they've done some work with their value-based purchasing program. So there's lots of information out there and that's what we basically try to do, like as Angie mentioned, with the transportation, with the in lieu of service, anything that has been brought to our attention that is a barrier, we do that research to see what states are leading those efforts and see if there are ways that, you know, we can mirror those efforts here in Kentucky, or the best strategies that we can implement that are most similar, you know, with the resources that we have here. And again, the Medicaid Innovative Collaborative has been crucial with helping us meet some of those goals, but some of the ideas that we have seen, I think it's created some growing pains and some strategies that we need to smooth out. But I think in the long run, we'll start to see some strides come through.
I believe at the last meeting, it was discussed that Kaizen something had been working with some of the MCOs.
I think yeah.
I think some of the MCOs said they were going to do like a joint application regarding that with the MIC. Was there any update with that?
So I do have updates with that. The Kaizen application was not selected as one that was going to be funded, but that does not mean that the MCO cannot continue those conversations and work through a contract with them. But the ones that were selected to go through were it's called Kentucky Farm Box, and that was with Passport by Melina and their community-based partners, Dare to Care Food Bank and Play Cousins Collective. And the others were with Samaritan and a co-application with Aetna and Humana. And Samaritan focuses on addressing homelessness. And then the other one was Free from Market, and that initiative was with Anthem. So if any of the MCOs want to speak further about their applications, then they can talk about that.
Hey, this is Leslie with Humana. You know, we did apply both for Kaizen and also we applied with Samaritan, and just are thrilled to have our application selected. So we know we're going to learn a lot with this pilot with Samaritan. It's our hope that we'll be able to see a strong ROI so that we can perhaps continue that pilot on well beyond the time frame of the grant application or the grant proposal itself. But we're just so excited to have the opportunity, and without the MIC funding, you know, we might not be able to test and learn from a pilot like this. So very appreciative of the department for inviting us to be part of the MIC and for this opportunity to pilot this.
This is Susan from Aetna, and I share in Leslie's gratitude. Looking forward to working closely with Samaritan. Happy to also be, you know, co-rewarded and walk through these steps with our cross-system collaboration with Humana. Implementation calls are commencing, right, Leslie? I think we have one tomorrow. Or I think we do at least. I'm not sure if we're all on it or not, but definitely the ball is rolling on the Aetna side with Samaritan. And again, we're very grateful and excited about this opportunity to serve our unhoused population.
Yeah, we're rocking and rolling on our side too, Susan. I know we'll learn a lot together. Excited to work with you guys too.
And this is Tabitha from Anthem. Again, as all the other MCOs have said, we definitely are excited to partner with Free From Market and looking at food as medicine and how we can contribute to healthy options for our members, especially those who have chronic conditions. So just excited for the opportunity to partner with them and excited to see the outcomes that may come about from this.
And this is Diane Coursey with Passport by Molina. As others have shared, we're very excited to be partnering with Farm Box along with Dare to Care and Play Cousins. We'll be focusing our pilot on a targeted group of diabetic members. So very excited to bring some healthy food options to those who would typically not have access to it, along with driving some further education so that we can see a really great ROI with our members.
This is Heather with WellCare, and we've been partnering with Good Measures and saw some really good success with them related to our diabetic and our cardiovascular chronic conditions population. And also we started with them focused on obesity, but have changed and added the diabetes and cardiovascular and have really seen some success with them. We're also partnering with Farm Box as well. So seeing a lot of really good results with that for our members.
Cool. It'll be interesting to see how going forward things go and what data comes out of this. Other updates from the MAC. I had attended, I was working at the same time, so I didn't have any specific things that I had heard from them. It had ran over quite a bit, so our recommendations, well, we didn't have a quorum, but I don't know if I heard of any recommendations from other TACs that dealt with anything specifically to equity. I don't know if anyone from Medicaid had heard anything specific, but none that I caught. I'm gonna just throw it into updates real quick because Rachel had said that Jeremy Thompson from the Transportation Cabinet was here to maybe be able to answer some questions if we had any additional things regarding transportation. I was going to put it on the next agenda, but if Jeremy's around, I would have a couple quick things.
Yes, I am here.
Great. One of the things we had asked is, well, in general, if you have any updates since the last time, you may answer my questions without speaking. I don't know if there's anything more you guys are working on doing with the data that you had gathered from the last time.
Hey, Jordan, this is Rachel Raird with DMS. Just to jump in from the last time we discussed follow-up questions for transportation, we had submitted that report on no-shows and cancellation. And so one of the questions that was raised by the TAC was wanting to know why those numbers are so high for cancellations and no-shows and how the process works for those members. So Jeremy, maybe if you can speak to that, that could give us some direction to go in.
Sure. So as far as the reasoning for the no-shows and cancellations, we really don't fully know or understand, other than no-shows are often we arrive and the member just, I don't feel well today, I don't want to go today, who didn't cancel in advance. They may find out we arrive and somebody else is taking me today, or oh, I canceled that and the vehicle arrived anyway, which it shouldn't have, but sometimes that happens if it's a late cancellation. No shows, really don't have much data to go on that. Again, a lot of times once we do follow up, it's I forgot about the appointment, or I had other things to do, or it's the variety of reasons, but there's no pinpointed reason why. And I don't have the data right in front of me. I'll have to look at that to see the areas that were higher than other areas. It could be I don't know if it's geographic location, or it could be there's, there's just different reasons, different there's just not one reason for a certain area in the region is what I'm trying to say. And a lot of times there's no explanation given at all. They just call in, I want to cancel my appointment today. That's the majority of the no-shows. They call in, or they'll leave a message, I need to cancel my appointment. A lot of times that's with the no-shows. They don't call and cancel at all. Therefore, when their vehicle arrives, they're not there at the place of destination or pickup destination.
One thing we had asked is, do the vendors reach out within a certain timeline beforehand, whenever they've had a trip that's been scheduled, to ensure that the person still is wanting to go to the visit?
Right. So we have different, we don't have different procedures, but there's different ways that the provider, we can't deny anyone if they are a frequent no-show or a no-show. That's prohibited from us doing that. So if we know of a member who has frequent no-shows, so many within a week or a couple of weeks, then once they're identified, then they will reach out. And if the trip is scheduled in the scheduling software, they'll first try to contact the member, remind them you have an appointment coming up. Are you going this day? That's scheduled. Is that still on? A lot of times they'll say yes, and they'll show up, and they'll no show again. Or they'll, if there is no call, or now a lot of no shows. I didn't mention this earlier, but we have subscriptive scheduling for members who go 3 days a week or 5 days a week, every week. A lot of our day program activities, the facilities send those in one time a month on those schedules. And so they don't call us until, hey, this person's sick this week, or this person's not going today. They don't accurately update the schedule before the vehicle is dispatched. So that results in a cancellation, or more likely a no-show, because those schedules aren't updated when they're sent in monthly for subscriptive scheduling. So then the broker has to go back and then we verify if there's a question that, is there a claim on this date? We go back and talk to the facilities or a doctor's office to see, did they actually show up for their appointment? Just kind of spot check as well. But so.
Okay. One of the things I had seen in the last one that really surprised me, I'm from Knott County, so it's a really small county in Kentucky, and I work, it's one of the days of the week I work over there. But so you had Jefferson County, you had Fayette County, and then you had Knott County, that was third in the state for cancellations, and it's a really small county, right?
Right.
I was extremely surprised that with such a small population, they would have such a high number of cancellations relative to the counties with larger populations. So I didn't know if there was anything you guys were doing to look at vendor cancellation rates, and if one vendor has a drastically higher number of cancellations, looking at why there's such a difference in certain areas, and if there's something that a different vendor is doing that is decreasing that number, whether it is more outreach or if there was anything on that topic, just looking at differences in cancellation rates and how to maybe help improve one or the other.
Right, certainly. And it could be that we have experienced, as an example, I thought my provider was going to be late, so I went ahead and canceled my appointment. A lot of when they schedule the trips, a lot of times they'll say, be ready 1 hour before your appointment time, depending upon the distance it takes to get from their home to the center. And sometimes we often hear that, well, my provider is going to be late. They're not going to show up on time. So I need to notify my medical provider that I'm not going to be on time or something. When in actuality, that schedule is still in process and they would make it on time still to that appointment. And that results in a lot of no-shows, cancellations. But our brokers who contract with the actual transportation providers, yes, they will go in and they'll look at when they get the trip data back, and it goes through a verification process every time. They check mileage, they check the pickup times, drop-off times to see if they're contractually abiding by their contract with the broker, because the providers themselves are not contracted by the state. They're contracted by the broker. And so, of course, we then give the broker what the standards are. So yes, to answer your question, they will go back and they will audit, or they will look at the trip data. If there's a reason or a situation that's occurring that's an outlier from the other providers, yes, they'll contact that provider themselves to try to figure out what's going on. A lot of times it's the member calling in because we're not aware unless the member lets us know here at the state office, and that will initiate, further review or further auditing to see what's going on. Sometimes we find out in the scheduling software itself, an appointment time changed, especially in the descriptive instances. Appointment time change that was never updated in the scheduling software, which caused some problems in their untimeliness or the arrival or change of address. The member moved, so therefore they're no show upon arrival, which is a big thing that we experience a lot. Or they're staying at another location with a friend or family member and they're outside of their normal area and they forgot to tell us. So it's just a variety of reasons in the whole no-show cancellation. We try to do the best we can with the tools we have as far as to try to, because it costs the provider. I'm not sure if y'all realize, but the provider does not get paid until that member is in the vehicle. So every time they go out to try to pick the member up and they're not there, or they cancel, or they no show on site, the provider gets $0 for that trip. So it behooves them to make sure that member is going to go, or they don't get paid that day.
Yeah. Julia, I know you had asked before regarding not necessarily on, like, with patients coming in and saying that transportation just wasn't there. I don't know if you have any specific questions regarding that.
Yeah, I think I guess the main question, so my experience is more that families have tried it a couple of times and found that it is unreliable, and so they just don't want to try it anymore. And the same with our care managers. I think the most information, if you could get and sit with a group of community health workers or care managers, they have some really good insights on challenges. So I guess my question would be, I heard from a case manager that they really tried really hard to get transportation for a person multiple times, and the transportation service continued to no-show. And is there a way that we can have a rapid response when that happens? Like, we don't want to, just submit a complaint, but like, no, we need transportation. Like, is there like a bat phone that we can call and say, okay, it's not working, we need somebody right now?
Right. So all brokers have what's termed, some term it actually like, where's my ride, to where it will bypass the scheduling queue and send you over for somebody who will look into that immediately. Our office, of course, for statewide, has the complaint line that if they call us, and we always try to encourage people, don't wait and call in 2 or 3 days later, because the more information we have and the more timely it is, we can still get you to your appointment. All we have to do is make a phone call and see what's going on with that trip. So, and they can call our office immediately. That's part of what our responsibilities are here, to help ensure that there's still time. Now, if it comes down to a provider error, many providers, and we'll ask them, to work with the facility to the quickest time, that if that appointment has to be rescheduled, which we don't like to see that, because that's delaying the care, forgo all the other rules and transport them as quickly as you can get there, so there are helps in place. We are a non-emergency service. It's a coordinated service. And so there's a lot that goes on in that background to ensure that trip takes place the date that it is scheduled. And so, there are the providers are held to fines and penalties of once they reach a certain number of trips per contract with their broker. And so, or if they find out that, unfortunately, there are providers that will write down that, yeah, I took them, and then we'll later verify, no, you didn't, so we had to recoup those dollars as well. So, but yes, we try to, if it's not an instance of the member being denied or, first we find out what the reason is. Why didn't that vehicle show up on time? Once we determine the reasoning, then we'll make the effort to try to get them there as quick as possible. If it's still time, if they call us immediately, then we can most likely still get them there, by dispatching another vehicle out to them.
Can you give us the phone numbers for those Where's My Ride, the back lines, and then remind me of your
Right.
number? And you can not right now, but if we could get those.
Yeah, we can give you our number, which is statewide, and then each broker's number, I can send the contact information over to Rachel or whomever, and it's the same number. It's just a different prompt, basically.
Oh, got it. Okay.
Yeah.
Jeremy, this is Kelly. I'll put my email address in the chat if I can get my computer to work.
Okay.
And you can just send those to me and I'll make sure the TAC gets them if that's okay.
Absolutely.
Yeah. Well, thank you.
And we set with, of course, DMS knows this, we attend many advocacy groups, share information with case managers, work with UK Institute. We try to be present a lot of the a day program meetings, and I'm actually going to be at the conference tomorrow with Adult Day. We try to be present to hear their concerns and hear any problems and issues, and in order for us to correct and improve. We want the service to be the members, if they qualify for it, they need to receive the service. And so we try to be present, and anytime there's an issue, feel free to send them to our office, because that's what we're here for, to make sure that they get the service they need.
Thanks. We're getting kind of crunched on time. Was there any specific area left on the agenda that DMS or any of the MCOs had prepared anything specifically for? I just don't want someone to not have a chance to discuss anything if they had a specific topic. But if not, great, I can go ahead. For care gaps, the only thing I had with that, and again, I'll try to be quick. From the MCO standpoint, currently, what specific things are they doing in order to, they're looking through the data, they're seeing care gaps and things like that. Are there anything that MCOs are specifically doing in order to try to address those areas? There was a form that I think Julie had sent me, or maybe it was a couple articles looking at how different, I guess, analysis are going on to see the gaps and to see, I guess, how interventions are actually making a difference. And I don't know if there's anything ongoing through the MCOs now that is looking at that and has gotten any data on it yet.
Hey there, I can speak on behalf of Humana. I'll say that, a lot of it is just looking at data across our membership to understand what they look like and assessing utilization of value-added services and our rewards to make sure that we're seeing all of our members, not just some of our members, actually taking advantage of those. We've also tied it back to our HEDIS gaps. So wherever possible, if we're trying to close gaps with HEDIS and we have the opportunity to also close some disparity gaps, that's always our first priority. And I think that too is a place where we're going to leverage this great new opportunity with Samaritan, thanks to the MIC proposal really being focused on identifying where we have the greatest disparities using the GARE tool to make sure that we are trying to address where we can. I'll say probably like every other MCO, we have a lot of work to do in this space. We know that we can't do it by ourselves. We're really having to partner closely with our providers, get a lot of feedback from our members. But those are a few examples. Not sure if that answers your question, but that's one way that we're approaching this work.
And this is Kate Miller from Anthem, and Danita actually was at our site last week for our showcase of healthcare innovations for the next era. Shine is what we called it. And we have a pretty robust population health management strategy where we have 7 domains of focus or areas of focus. And then within each one of those, we look at what group is being most negatively impacted. And so we look at things like race, geography, age, gender, just various categories of people that may be overlooked or left behind, or maybe not responding to care in the same way. So we've been doing it for a couple of years now. And one of the outcomes that we saw from 21 to 22 was we had identified a disparity in our Black membership, predominantly in the Louisville area, that had a higher rate of diabetes, poor control. And so we did some targeted interventions around that. We did some cooking classes at Dare to Care on how to do healthy eating. We did some targeted outreach to that population, and the rate of members with poor control dropped significantly, and the rate of members with good control for our Black members increased significantly, so significantly that this year our focus has become geography for diabetes versus race, because the targeted interventions that we did for our Black members is sustaining, and their rate of good control is holding steady with year-over-year improvements. So love to tell you guys about our Shine event and maybe show you some of the posters. And Danita, I don't know if you want to jump in and give any feedback on how that went, but that did happen last week.
Yeah, sure. We came back. We were energized. Letha Harris and I both attended that event. Letha represents population health, so we did see some. We enjoy the operations meetings that we have with the MCOs, but being able to go on site and see in much more detail, and I did compliment their posters. Just to see in much more detail the activities that they're doing and the strategies that they're doing, it provided a greater picture, and it gave me the opportunity to come back to our team with some ideas, because had some conversations, and some of the things that we were actually thinking of doing as we are trying to update and revise our reports are some of the thought processes that Anthem's team were already incorporating. So that was good to learn, but it was an exciting event, and we enjoyed seeing the great work that they were doing. They talked about doing this event moving forward and partnering with other MCOs to do that, and I thought that was an excellent idea as well.
Right. And it's more, things like that show tangible data. I think anything like that would be great to show, so we can take a look at what specifically was done and how it could maybe be implemented further. Got like 2 minutes left. Real quick, we had asked last time if there were any specific reports regarding different health outcomes highlighting disparities. I know we've asked before on that. I didn't know if you guys had anything to share. It could be sent out to us after the TAC meeting, if so.
This is Heather Hale with WellCare of Kentucky. We do have some reporting that we've developed on our HEDIS measures that we can share related to health disparities, where it reports out the information related to race, ethnicity, region, it shows a heat map as to where our population's at. It's really very intuitive and nice reporting that we're able to use and incorporate into our work group. So we're excited to be able to use this data to help drive our interventions and improve our outcomes with our members. So we can share some examples.
That'd be great.
Hi, this is Kelly Sheets again. I would just
Mhm.
ask that if any of the MCOs do have reports to share, if you could get me those by noon tomorrow, I'll get those sent out to the TAC if that works for you, Jordan.
Sure. All right. A couple agenda items for next meeting. Wanda had helped or had created this agenda. So specifically on the value added benefits, I didn't know if she wanted any specific presentations. If maybe a presentation looking on, I know we've gotten sent value added benefits before, and at least a sheet of what's available. But if it could be like a presentation on if the data is available on what value added benefits the MCOs have provided, and looking at different, whether it's utilization rates or if they're looking at any outcomes that those value added benefits have provided, that could be useful. I don't know if that would be something that could be done or not. The other thing I think Rachel had brought up last time, that they maybe had a presentation for homelessness, and I think Angie had said that there was some data that they had looked at and for that as well. So homelessness could be another topic we can cover at the next meeting. But yeah, I think that's about it for today. Now, if anyone else has any other comments, feel free. Otherwise, we will adjourn for the meeting.
Thank you.
Thank you, guys.
Thank you.